Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So on this episode, I'm talking to someone who's had a very positive influence on my career and on the careers of hundreds of physiotherapists and other health professionals around Australia and around the world. And that someone is Associate Professor Jane Rooney. So there's every chance that you know all about Jane's background and experience from your reading and from your for all the work that Jane's done. She may not need a lengthy introduction, but for the context of this conversation and what we're going to talk about, I do want to give you some highlights so you know where we're coming from. So Jane's a specialist sports and exercise physiotherapist, as awarded by the Australian College of Physiotherapists back in 2009, and a facilitator and examiner for physiotherapists completing their specialisation with the Australian College of Physiotherapists. So Jane has extensive experience in sports physio, working with all levels of athletes, from the recreational athlete all the way up to the highest level of competition. And her clinical expertise and specialties in the knee, and that's what we're going to be talking about today. Jane has a long list of university teaching appointments and clinical courses that she runs, including the Physio Educators platform. Jane helped launch the GLAD program in Australia, and she trains the physios who train the physios who deliver the GLAD program, sort of like a Top Gun instructor. And on top of all this work in clinical practice and education, Jane is pushing our profession forward through research and her work with knees. She was awarded the prestigious Churchill Scholarship 9 years ago now, looking into how knee injuries are managed in different countries around the world, and just has taken that information back into what we're doing here in Australia, and is leading this paradigm-changing research that we're going to talk about today on cross-bracing, non-operative ACL injury management. So I can't wait to get into it. Let's bring her on. Jane Rooney, welcome to Physio Foundations.
Thank you, Luke, and thanks for that kind introduction.
So good to see you again. Anything you want to clarify there in the background? Anything else that you would add?
My Churchill Fellowship was which I was awarded in 2016, and I travelled for 3 months in 2018, just got it in before COVID, luckily, to all sorts of countries, but UK, Netherlands, Denmark, Sweden, Norway, and Ireland, as well as the States. And I was particularly looking at ACL injury management algorithms, non-operative programs, rehab programs, post-op programs, and prevention programs, and also algorithms of triage and care, and also looking at different health systems in those different countries to understand how ACL injuries are managed from a health policy and funding point of view, which has informed some of the research that we're going to talk about with shared decision-making.
And that gives everyone a nice background to how you got to where you are and why you're focusing on this area. So before we go into it, for people listening to this, let's do a disclaimer, which I normally have in the show notes, maybe at the very end of it. This is a conversation for health professionals. So please see a health professional for your own health needs. And we're going to talk about cross-bracing, the cross-bracing protocol. There's lots of resources, lots of training you've been doing and research you've been leading in this area. You'll take us back to what it is and we'll go through it from the beginning. And one of the things I want to cover here at your request is let's make sure we have safety first. Let's do our Hippocratic oath of first do no harm and make sure that we're giving the correct messages for people listening to this about how to safely approach this non-operative management. Yeah. So do you want to take us back to the start and sort of link what you learned in your Churchill Fellowship to
sure.
where we are now?
I mean, part of the reason I was awarded the Churchill Fellowship, for those of you who are not aware of it, but basically you need to identify a common problem for the common man in a Commonwealth country. And you need to understand how your research may affect potential management strategies, or how it would change practice if you went and learnt something from overseas countries that you can't learn in Australia. And one part of that is, in Australia, we have the highest incidence of ACL injuries in the world. And We also, unfortunately, the predictive modelling says that, and this is not only in Australia, but it's been predicted in the US, Finland and Sweden, so a number of countries that are looking at this. It's set to double by 2030, so in the next 5 years, and most alarmingly in the 5 to 14-year-old age bracket. And I suppose
it's very young, isn't it? 5 to 14.
Yeah. And it's quite alarming to think that, if we look at the long-term knee health stats, 50% of these people don't return to sport. 50% of them also have knee osteoarthritis changes 10 years post ACL injury. So potentially we have 15-year-olds who have, knee OA, which affects, broader health, has broader health implications. And in Australia, the other factor is that we also have a 90% operative rate to manage ACL injuries, which is quite different to places like many places that I visited, Sweden, the Netherlands, the UK, Norway, where they have more like a 50% operative rate, which was another part of why I was awarded the Churchill Fellowship, because I could point out some of these differences that we have in our management in Australia compared to other countries around the world.
There's enormous financial implications of how these are managed as well, and the cost on the person and on the society. So,
correct. And I think in Australia we spend something like $175 million per year on co-payments, which is, with the doubling of rates, is set to increase to about $300 million, which is a lot of money to spend on co-payments. And most of this surgery, 80% of it's done in the private sector, whereas a lot of those other countries that have more like a 50% rate, the health system is predominantly public. So I suppose there's more control of the health dollar spend in those countries.
So that gives us some background for the problem.
Yeah.
And you gathered intel on what other countries are doing through the Churchill Fellowship, and you brought that back. And so what's happened in the last 9 years in the work you've been leading in this space?
Yeah, well, I suppose the other important thing to look at is that if you look at the two RCTs that have been done looking at outcomes on non-operative versus operative care, there's no difference on average in outcomes between knee function, knee quality of life, return to sport, additional meniscal surgeries or injury or osteoarthritis rates. So in fact, that's part of the interesting thing, is that I suppose that with our 90% operative rate, there's actually no evidence that actually drives that rate if you look at evidence-based practice. And so that culminated in when I returned, I started talking to Associate Professor Stephanie Philbay about this, and talking about how we could possibly drive some better health literacy amongst patients to make a better informed decision based on peer-reviewed published research evidence on non-operative versus operative care for ACL injuries. So we conducted a couple of surveys, one with physios, and that was about 230 physios or so, and then one with patients, which was about 600 plus patients. So, and the results of these surveys actually helped us construct what's called a patient decision aid, which is a free online tool which you can access through a website, www.aclinjurytreatment.com.
And that will be in the show notes.
And yeah, this actually walks people through. So I've torn my ACL. What does this mean? What are my options? How do the outcomes compare? And although it doesn't, spit out an answer like AI would or anything like that, it does enable them to have access to good research information so that they can go and have probably a more meaningful conversation with their healthcare practitioner about what options might be best suited for them based on their individual needs and desires and goals.
And the key word you said there was individual.
Yeah, that's right.
Yes, we're looking
for different.
We've got a complex health problem here that we're talking about. And yes, everyone wants an answer. Do I do this or that? But of course it depends. Of course it's individualized, and that's the nuance, and that's what we're focusing on here.
Yeah, absolutely. And because everyone, like if you had a 20-year-old athlete who was bound for, well, if I take one of my athletes, say as an example, a young girl who was bound for the Paralympics, and she ruptured her ACL, and she was 9 months out from Rio, and she trained her whole life to get to this pinnacle of her sport. And of course, she was so excited that the surgeon could fit her in ASAP, so in a couple of days, to get her reconstruction done so that she could then get on the track to train to hopefully make it to Rio. But that's very different to somebody who maybe is, say that 30-odd, or even if they're the same age as her, young 20s, and maybe they don't have a really high pivoting, demanding sport or job, and maybe they don't have private health insurance, and a whole number of other factors that you need to consider. And, the evidence would say that she should undertake, or they should undertake, a prehab program for 3 months first, and then decide, do they have adequate knee stability for their demand? Are they satisfied with their knee function? And we also know those people who do prehab first actually do better with the surgery if they do go down that pathway, rather than early operative management like our athlete did, for a very different reason. But some people just think because athletes take a certain pathway, that must be the best pathway for all, but that's not true.
And that's such an important message to reinforce.
Yeah.
It's so obvious when you say it. There's just completely different reasons for doing the surgery for the athlete bound for Rio compared to
And
else.
It does require a number of skills from the practitioner to have these conversations. One, you need to be aware of what the evidence is between the two options. And then two, you actually need to have good communication skills to glean from the patient, what do they want to do? What's their current demands in their job and their sport and their life? And what are their future proposed demands, and what's their insurance situation, and what's their family situation? Can they have surgery now or not? Or, all sorts of things. And then it relies on your unbiased communication skills as well, so that you can help to guide them as to what they want, what would be best for them, rather than trying to impose your views or values on them. And that's certainly something that we found very interesting from some of our surveys, in that when we surveyed the physios, 60% of physios said that they were aware that ACLR and rehab had similar outcomes, but only 37% of them told their patients that. And the other thing that was very interesting, 23% of physios said that an ACLR was necessary to return to sport, but nearly 80% of them told their patients that they had to have an ACL reconstruction to return to sport. So there's a real mismatch between what they said they knew but what they actually told patients. And that was also reflected in what we gleaned from the patient's information when we surveyed the patients, and learnt that nearly 80% of them were told, 74% of participants were told by a surgeon that an ACLR has better outcomes than rehab alone, and 85% reported that a surgeon presented ACLR as the best option for them. So you can see there's a bit of a mismatch between what we're talking about, individualised shared decision making.
So there's still some work to go. This is for those following along. This one's published in Physical Therapy and Rehabilitation Journal. That's last month of where we're talking today. So 13th of March, 2025. So it's hot off the press, and I'll put that in the show notes as well. Yeah.
And I think the other important implication for us in Australia as well is, shared decision-making and informed consent has important medico-legal considerations as well and implications, in that there has been a test case where a patient actually did win a case against a hospital for inadequate shared decision-making, in that they weren't presented the possible advantages, disadvantages and alternatives of a particular management strategy. And the management strategy he was advised actually caused a negative outcome for him returning to work. So it had long-term implications financially, socially and everything else.
Is this an example of treating the knee and not the person in this case?
Exactly. So it was actually an Achilles tendon rupture, but it could be an ACL as well for similar reasons. Yeah.
So individualised is the key word that keeps coming up here. So if we've got two broad treatment approaches for ACL injuries, operative and non-operative, can we talk a bit more about the non-operative approaches and lead into the cross-bracing protocol and give some context to what this is and what it isn't and who may benefit, who may not?
Absolutely. So the cross-bracing, firstly, if we talk about non-operative management, it's always just been physical rehab alone as the alternative to the operative pathway. But I'm going to now talk about a possible another option for people, which is bracing for native ACL healing. And I suppose this was first published by Stephanie Philbay, actually, when she looked back at the Canoon trial, which is one of the pivotal RCTs comparing non-operative and operative management. And she actually looked back at their MRIs and found that 30% of people in the delayed ACLR, if required group, actually had evidence of healing of their ACL on MRI. And if you then excluded those people who then crossed over to ACL reconstruction, that number went up to 53% of people that actually had evidence of healing at 2 years and about 58% at 5 years. And interestingly, the outcomes for those people, they had better quality of life scores and other subjective scores than the than the ACLR group, as well as the non-healers. So interestingly, the healing group did better across a number of domains, and they were totally unaware of their healing status at that time.
That's interesting. I've heard that before, that people are just surprised that they've had spontaneous healing
They were never told that was an outcome that they were being measured, and they were never told what their healing outcome was. So I suppose that those measures of knee function couldn't have been influenced by any psychological factors of knowing that their ACL was healed or not healed. So that was one of the first pieces of evidence that was published, a good quality evidence, and actually caused Google to change their advice. A month before, it had said on Google that the ACL has no potential to heal because it doesn't have a blood supply. And then Google, a month later, after this paper was published, said, ACL can heal, and maybe this is the key to better patient outcomes. So I was quite surprised that Google was so nimble, much more nimble than many of our healthcare colleagues, actually.
And that's such an important resource for people. It's the first place you go.
Yeah.
A lot of the time on the way to higher quality resources. So that's really good. Even Google was listening.
Yeah, that's right. So, and alongside of this, Tom Cross, he is a sports physician in Sydney, and his late father, Mr. Mervyn Cross, who's an orthopaedic surgeon in Sydney, it was sort of an accidental discovery where a patient turned up and absolutely didn't want surgery for her ruptured ACL and was prepared to try anything else. And Merv said that back in the old days, they used to plaster people at 90 degrees. And I actually do remember these days. When I first moved to Melbourne 30-odd years ago, there were a few people still doing that. And of course, they didn't have MRIs back then. So Merv said, well, some people used to do okay, and we've got no idea why, because we didn't have an MRI scanner back then to even know what happened. But of course, it did come with a lot of morbidity from being in a plaster for a period of time. So Tom then said, well, nowadays we've actually got braces that provide very good fixation and not quite the same morbidity as a plaster of Paris encasing the whole limb for that period of time. And so this patient said, well, she'd give it a go. And so she was patient 0, and so she got a very good healing outcome after 9 weeks in the brace. And we now know that she has the type of tear that does heal well in the brace. And that was probably a lucky accidental discovery, because I suppose if it had been one of the types of tears that we know don't heal so well in the brace, that might have been the end of the project there and then. But Tom kept going over the next number of years, and I met him in 2020 when I was presenting at the Australian Sports Physicians Conference, and he was presenting his first 16 or so patients in this case series. And we decided at that conference we should collaborate, because I was doing the shared decision-making work and he was doing the cross-bracing, and we thought it would dovetail very nicely together. And so I braced number 17 patient in Melbourne, and then COVID happened. And of course, as we know, elective surgery shut down, and there were a number of people coming back from skiing trips and so forth overseas with ACL injuries. So we did brace a number of those over the time, because they didn't actually have a surgical option at that time either. Yeah. So that was sort of partly how it came about. And then, of course, you probably are aware that we then published the first 80 in the case series in 2023 in BJSM, which surprisingly showed a 90% healing rate of the ACL.
It was big
bracing
news at the time.
It was big news.
Still is a big discussion point, yeah.
It is, because up until that time, there was really not, even though it's a case series and it's obviously lower level of evidence, it certainly added to the ACL healing evidence and the possibility that the ACL could heal. And also, I suppose, that research also showed that they had better Lisham scores, better return to sport scores, and it was related to their quality of healing as well, in that if they got a better quality heal, what we call an ACL OS of 1, they did better than if they got either a longer or thinner, or a longer and thinner heel, which is what we call an ACLS of 2. So those people had slightly poorer scores on their Lisham scores and their return to sport scores, and they had more knee laxity as well. So, but if we compared the results to the Canoon trial, it would seem from that case series that if you brace the knee, appropriate knee injuries, and we'll talk about that in a minute, it seemed to result in better rates, but also better quality of ACL healing.
It's proof of concept for the next stage, which is the RCT that you're involved with, that Stephanie Philbay from University of Melbourne's leading. Anyone in this field, in working in this area, should be aware of all the studies you're mentioning, and it's probably something that they've heard before. If not, go ahead and read these studies and then catch back up on this area, because this is a really good summary of where we are now, how we got to this point. Yeah.
I suppose the other disclaimer that I should also mention is that we do need to be very aware that if we go back to those 2 pathways without bracing, looking at non-operative and operative management, 50% of people who undertake non-operative management will cross over to surgery. So they really do need to be, non-operative management alone is not suitable for everyone either. Do you know, because it might cost them more time and inconvenience, in that they might invest 3 months in a rehab program to find that their knee is still unstable, and then they need to cross over to surgery. And in Australia, that comes with time and also costs, because they have to then pay for surgery and they have to pay for the rehab again. And that's probably why a lot of elites take surgery straight off, because they just probably don't want to spend the extra time for the risk of outcome. But this bracing is a different pathway in the non-operative management, in that our re-rupture rate when we published was 14%, and we're now over 1,000 patients in our case series. So, and it's still sitting around that. So it's sitting at 15% right now. So we've been watching that. And if you look at the ACLR broad evidence, it's between 25 and 30%, depending on your age and your return to sport and, your gender and all those sorts of things. So it certainly seems to be equivalent, if not slightly better.
And if we talk about the anatomy underpinning all of this, so we go back to the foundational anatomy here. So some people can have a spontaneous healing of the ACL. It seems to have something to do with perhaps avoiding extension, the close pack position of the knee joint, which would put tension on all the ligaments, including the ACL in the early stages. It would be good to talk about the mechanisms of how it heals in a braced position, but also maybe how spontaneous healing happens for some people.
Yeah, so let's talk about firstly the bracing position and how it was chosen, and then I'll weave it into spontaneous healing. So Merv Cross chose 90 degrees at that point. And if you look at some of the data, that actually it shows that at 90 degrees, both bundles of the ACL are in a shortened position. Of course, they're more short if you come into further ranges of flexion, so 120, 130, but then you've got to consider the compromise of the neurovascular structures at the back of the knee. So 90 degrees was chosen as sort of a safe shortened zone to brace the knee. And this, if you like, opposes the two ends of the ruptured ACL so that they have less distance to actually come together and heal. So I suppose that's why the bracing angle was chosen to be that. And this probably also relates to spontaneous healing in that, say, if people rupture their ACL and they have a big hemarthrosis, which is obviously a bleed into the knee, which of course is part of why it heals, because Google used to say that the ACL doesn't have a blood supply. So I was told that also by many other people, but that's actually incorrect anatomy-wise. So, of course, the hemarthrosis, if you like, splints the knee out of full range extension. So probably if you had a hemarthrosis and you just sat around and you had a desk job and you just let your knee sort of do what it wanted to do, it would probably splint it naturally for a couple of weeks in flexion, unless you went to see a physio who put you in a Zimmer splint into extension and then tried to push your knee out as quickly as possible into extension and get the quads working and get you walking on it in a straight leg position. So we've probably done some of these spontaneous healing ACLs a disservice in the past. And we've actually got a slide in our course materials, which I've called ACL First Aid, which actually makes people aware of, if they do want to keep all options open, don't splint them in extension in a Zimmer splint. Don't aspirate their hemarthrosis.
Such good points, such good education points that are so counterintuitive if you think about managing other injuries in the body.
That's right. And also don't repeatedly test the ACL as well. So if you have a high index of suspicion from the subjective examination that they have an ACL injury, so they've, had a landing or a cutting or a pivoting injury, and they've, said that they've heard or felt a pop and then their knee felt wobbly or weird, and then they got sort of swelling within a few hours, that's a pretty consistent picture that it's probably going to be an ACL injury, or they've certainly got a hemarthrosis. And then you need somebody who can test the ACL well, somebody who can do a Lockman's and a pivot shift, so that you do, a once-off good examination and then send them for an MRI, which in Australia, thankfully, happens quite quickly if you put an urgent sort of sticker on it, and they can get to a GP in a timely way. And For the cross bracing, we prefer a 3 Tesla MRI because it gives us a better quality image, and we also like a double oblique sequence because that gives us a good image of the femoral footprint of the ACL, which is one of the important factors that we look at. And from then, they should be on crutches, non-weight bearing, with their knee protected, not necessarily in a brace, because if they do go down the bracing pathway, you don't want them to invest a lot of money in a brace that may then not be appropriate to do the cross-bracing protocol. And also they need to make sure that if they're going to be non-weight bearing, that they keep their circulation exercises going so that they are safe and they don't predispose themselves to clotting. And then they need to get to somebody who actually knows about how to share decision make people for if cross bracing is an option for them or not. And I suppose this is where we want to talk about the Hippocratic oath of do no harm, because unfortunately with the popularity and media exposure of the cross-bracing protocol, we've had a number of people who've been braced inappropriately by physios around Australia and the world actually, where they maybe didn't have any chance of healing in the brace, and some people haven't also been put on anticoagulants. So that's the danger part of it, in that 2 of the first 11, when we didn't have an anticoagulation schedule, got DVTs. So this is a really important danger factor, in that if people get a DVT and then a PE, you could actually kill somebody doing this protocol if you don't do it appropriately.
Yeah. So just to really reinforce that, yes, there is enormous promise for individuals with the shared decision making.
Yeah.
And there's risk. There's risk of death in there as well. So we need to take this seriously. And there are resources people can read up on. There's courses we're going to talk about that you have been putting together related to how to get people safely into, the start of the decision making would be the start of the protocol. But just really be careful. So, two main harms there: the risk of harm from anticoagulation or lack of anticoagulation therapy. And potentially the risk of bracing someone unnecessarily. And this
the
person
risk of exactly
wasn't going to heal anyway, and you're wasting their time.
Like an example of that is we've had a young construction worker who then had to give up his job for 8 weeks because he didn't see me for a couple of months. He was from regional Australia, and he didn't have a chance of healing in the brace anyway, and he couldn't work for 8 weeks because he wasn't allowed on site in the brace.
Right.
So that was really financially disadvantaging him, which he was quite angry about, in addition to the fact that he hadn't been put on anticoagulants. So he was also, it was 1, unsafe, but 2, he had a lot of financial distress from being braced unnecessarily and inappropriately. So I suppose this is why it's really important that physios work in a team with a doctor, a physio, and you also need the appropriate radiology, imaging quality, but also images. And then also you need a surgeon on board for those people who either are not appropriate, or some people have to go back to surgery, and we can talk a little bit about that, either if they fail or if they have other concomitant injuries that may need delayed surgical repair. But I think we should probably talk about some of the inclusion criteria so people are aware of who may be appropriate for this type of treatment. Do you think?
Because somebody who's working not in this specialty field but in a private practice, for example, may be asked about the options, and they should know. And they've got resources now, thanks to you and the team, they can go to and read up on and direct patients towards. But part of that conversation early on will be whether you're likely to be eligible. And
that's right, yeah.
So let's talk about that.
Yeah, so if we look at some of this information that's come from us retrospectively looking at our data set and working out who healed and who didn't, and what were some of the common factors in these groups. So we now know that really it's ideal if you brace before day 16, because after that time, it seems that healing, probably a bit like, say, if you did a really deep cut and you didn't stitch it in a timely way, it would probably heal separately. It's something like along those sorts of lines, in that we see that people who are very delayed, it's like the ACL heals in two separate bundles. Do you know where there's no continuity between?
And that's on MRI.
The ruptured, the ruptured ends. We're seeing that on MRI. Yeah. And this is a variable. So there's no set. Like, I've had some people who've had that look on MRI at 5 days, and other people that are still, what Tom says, open for healing, especially if they're younger. They seem to be open longer for healing. Up to 28 days, which we had in our case series. But generally we say within the first 16 days is good to brace somebody. So you understand the urgency of time. Then by the time you've done the injury, then you get to see a GP, then you have your MRI, and then you've got to see somebody who knows about this. It's quite time pressured. Okay, so that's one thing. So then we look at the actual MRI factors of the ACL tear. So we know from looking retrospectively at our case series, not all tears are the same. So some ACL tears happen in the mid-substance, and the femoral footprint is not interrogated at all. Other people rupture part of their femoral footprint. So it's like the ACL comes out of that part of the origin of the ACL, but only partially, and very rarely, so we haven't got many of these in our case series, they pull the whole femoral footprint off. But these tend to be high-speed, high-violence injuries. Like I had one like that. She was an Australian level skier. So, of course, she's going 90 kilometres an hour very fast when she crashed. So there are some of the MRI factors that we look at. So we look at where the injury is. We also look at how much displacement. So you could imagine an analogy would be, say, if you had a sausage and the sausage skin was intact, which is the synovial envelope of the ACL, but now the sausage meat is separated inside it. So that's like
that was the question
ACL.
I had for Tom. I asked Tom that question. I want to ask you that again. Just to recap the anatomy for listeners, the ACL's intracapsular, extrasynovial. So the synovial membrane is wrapped inside the knee joint around the ACL, and that's highly vascularized. That's a part of that hemarthrosis you were talking about. You're tearing the synovium, it's bleeding, which may be a part of the healing. Fascinating.
Yeah.
So then my question was there, how much is the actual intact synovium and maybe some strands of the ACL? How much is that a factor in it all coming back together again?
Because, of course, we know, say, with the ACL anatomy, the whole ACL is actually encapsulated by a peritoneum, which has a synovial lining of its own. Do you know? So, and then if you rupture the ACL, sometimes it's like the ACL ligament actually ruptures inside that envelope, but the synovial envelope is now intact. So that's what I was saying. It's like the sausage meat has separated, but the sausage skin is intact, because, of course, that gives it a perfect trellis, if you like, and it keeps it in line. And you could imagine the healing would be easier in that situation. Whereas if the synovial envelope is then breached, you see variable amounts of displacement of ACL tissue outside of that synovial envelope. And so we think that if you have less than 20%, which is a little bit arbitrary because, of course, the radiological paper hasn't been published yet, so it's more Tom and his radiologists and some of the ones in Melbourne as well who know how to classify this and look for this. It's really looking at the percentage of displacement of the ACL tissue. And so obviously you could imagine if now quite a lot of that sausage meat has then fallen down, then it's much harder to find its way back up to meet its buddy at the other end. Although in some cases we've certainly seen that happen. But sometimes they are the ones that heal with a slightly thinner heel. So it's like some of that displacement hasn't actually made its way back to the main ACL ligament. And, the body has a way of, sending those scavenger cells to either eat up that tissue that's not required, or sometimes it forms a little ball of scar tissue like a cyclops lesion in where that displacement was. And the other thing that we look at is the femoral footprint. And certainly if you pull more than 20 or 25% of that femoral footprint out, again, those people tend to heal or could heal, in our case series we've seen, with a slightly thinner or looser heel. And so we look at acuity to tear, we look at the actual tear itself as far as where has the tear happened, how much displacement of the tear, or is the synovial envelope intact? And then also what's happened to the femoral footprint, which you can only see on the double oblique sequence, not on the axial view. So that's why we ask for the double oblique sequence. So they're the sort of MRI factors that we look at, and we have trained a number of radiologists around to actually comment on these factors, but the standard MRI or radiology report doesn't actually usually include these factors. It actually requires us to retrospectively report these for inclusion or exclusion in a shared decision-making way for the cross-bracing protocol.
It's fascinating how quickly this has evolved as well. To just sort of summarize here, back at the beginning, when the person's first most likely ruptured their ACL, we want to keep the options open by not over-examining the ACL, which is putting tension and pulling it apart further, leaving the blood inside the knee joint, so the hemarthrosis is a part of the healing, not necessarily pushing extension if we want to keep that option open of bracing or non-operative healing, bracing before day 16. And then we're thinking about the displacement, or you are, and the team and the case series has looked at the displacement and the location on the MRI. How do you get those special sequences? Well, maybe a broader question is, if you're working in your local clinic and you are developing a special interest in the ACL and you want the person to have the best management, maybe the best management for them is non-operative. It could involve bracing, but you don't necessarily have the skills and the network to do it. Do you lose that person as a patient for the better good of them? Do you refer them to a bigger clinic who's doing it? How do you manage this?
Yes, that's a very complicated thing at the minute, because of course it's very novel, this approach, and as you would understand, most research takes about 17 years to be adopted into clinical practice. So we're really pushing the speed of this, because the very first patient was braced in 2014. Our research was published in just the case series in 2023. So this has been offered as a management for people currently in Melbourne and in Sydney predominantly, but also there's a big case series in New Zealand as well at the minute. And so I suppose at the moment it's really, if you are aware of this and you are talking to the patient about their options of operative and non-operative, and if they want to explore cross-bracing as part of the non-operative pathway, which incidentally is a lot cheaper than surgery if they don't have insurance. But I think it is probably wise to refer them to somebody who actually knows about this. And knows how to, one, classify them, two, do the shared decision-making appropriately. And say, if it's me in Melbourne, I work at Prahran Sports Medicine Centre, I work closely with people either by telehealth if they're regional, or certainly I'm happy to work in conjunction with their local physio. But we do the initial brace fitting and do the workup as a sort of specialty service, because until we get the education more broadly out there so that patients physios are more aware of a lot of these factors, then I think to do it properly, you need to have some specialised knowledge, which is probably not broadly out there at the minute. Because the other factors that are important besides the MRI factors are the medical factors, in that they need to be able to take anticoagulants. So as you mentioned before, anticoagulation has risks of itself. So we started off using Clexane, but people don't really love injecting themselves usually. So then we changed over to rivaroxaban, or Xarelto is its common name, on advice of hematologists and vascular physicians. So that needs to be taken until they're fully weight-bearing. On or off crutches, but generally fully weight-bearing. So if you're doing a 12-week protocol, that can be up to the 8 or 9 week phase. And obviously the risk of that is that you have more bleeding. Do you know? So, if you cut yourself, you bleed more readily and more heavily. The same for women with their menstrual cycle, they have heavier menstrual bleeds. So there's a number of factors that need to be considered. And some people actually can't take anticoagulants for medical reasons. And the other thing is some people have an extra coagulation risk. So because of medical factors or family history. So the different clotting factors that people have. And if they're more risk of clotting, then they have to have a different anticoagulation schedule. So this is why you really need a doctor involved. As well as the doctor usually, say if it's Tom Cross, he obviously knows about all of those things, as well as the MRI factors, as well as some of the other factors we look at, concomitant injuries. So do they have a big bucket handle meniscal tear that isn't appropriate then for bracing? Do they have a multi-ligament injury? Do they have a fracture? Do you know those sorts of things that then precludes them from the bracing protocol? And then the other factor, which certainly the referring physio, even if it's not somebody who knows a lot about cross bracing, can screen their patient out, is the person factor. So do you think that they can handle being at 90 degrees in the brace and non-weight bearing for up to 4 weeks with crutches? Or do they not have the upper body strength or capacity to be non-weight bearing? Or maybe they have a job where they can't non-weight bear and they don't have private health insurance, and maybe it's not on work cover, so they can't actually afford to actually have that time off work. Or maybe they live upstairs, 3 flights of stairs with no lift, and they can't do that. So there's a number of different person factors that need to be considered. And if it's your driving leg and you can't drive for up to 12 weeks, well, sometimes that's also a consideration. And if driving's your job, you're an Uber driver or a bus driver, that's also precluded some people from bracing.
It's tempting to talk about ACL grafts and healing and synovium and everything all day, but these are very practical things that have to be considered. I think so. Yeah. To summarise, if you are still learning about this topic, there are lots of resources that there's experts like yourself, Jane, you can work with. There's also a lot of information that's coming out. You're trying to push it along and cut down that normal 17 years of research to implementation, but it's still in the infancy in that way. What does the future look like, do you think, maybe in 15 to 20 years in this area? Do you think it'll be?
Well, that's interesting. I think that I would see, but I suppose the RCT will tell us more. But I mean, the evidence of 1,000 patients in our case series is pretty undeniable that the ACL can heal. Do you know? And
the proof of concept is there,
and we can. It seems that we can assist it to heal better than if you just do non-operative rehab alone.
And so far, sorry to interrupt, 14% re-rupture rate in those over 1,000 people. And what's the average time of re-rupture?
That's at 12, that's collecting the 12-month data. 12 months.
And the question everyone has is, what about long-term re-rupture rates? And that's coming in the future.
I suppose that's going to be a long time coming. But so that's the evidence that we have for the people that have reached 12 months, which the thing is, it would seem that the poorer quality heels, so the ACLOS of 2 heels, the longer or thinner or long and thin, have a slightly higher re-rupture rate. So that's what we say. We think not all heels are the same.
Right.
So if you're a younger or highly pivoting sports person or person, maybe you want to be aiming for an ACLOS 1 heel. Do you know that? So when we do a particular shared decision making, we say your day 14. This is what your gap distance is between the ends of the ACL. Sorry, that's one other factor that I didn't talk about with the MRI. Is how big the gap distance is. So if it's more than 8 millimeters, we also think that it has a poorer chance of healing. So if we say you're this age, this is your demand, you're this many days post-injury, this is your gap distance, you have no displacement and no femoral footprint interrogation, we think from our data you have an 85% chance of having an ACLOS 1 heel. This is the sort of level of shared decision making we do for people. And we say, some people will get better or worse than that, depending on factors that we don't know or can't control. But at least they have some sort of information to make a decision on. So sorry, what else were we talking about there?
That's really good. I was really more interested in you gazing into your crystal ball that must be there in front of you and sort of thinking what the future may have in
so I think in the future, I think that it will be an option for people as one of the options. Right. So I think it will probably end up being that you have, surgery, surgery and non-operative care, and surgery being delayed or early, and then non-operative, probably bracing versus rehab alone. And in the bracing protocols, we actually, just to make it a little bit more complicated, we've got a number of different protocols now. So the initial protocol was a 12-week protocol with 4 weeks at 90 degrees, and then gradually extending the knee out by 10 weeks. It is at full range of motion. And then the MRI to assess healing is at 12 weeks. But now we have an 8-week protocol, particularly for people who have MCL injuries, concomitant injuries, because they tended to get a little bit more stiff. So that's some of the other things that we should probably talk about is the pros and cons of the bracing protocol, because there's also shared decision-making when it comes to that. And then we also have a 6-week protocol. So the 8-week, they spend 3 weeks at 90. The 6-week, they spend 2 weeks at 90. And then a 30 to 90 protocol if you just can't really handle being at 90 degrees, which will still get you a better heel than if you didn't brace at all, we think, but probably not as good as if you could tolerate to brace at 90. But of course, none of these bracing protocols have ever been, researched against each other, because we're nowhere near doing that. We're just doing the first stages of comparing non-operative bracing compared to surgery at this stage.
And that's probably one of the most important reminders for everyone listening here. This is amazing. It's rapid, but it's also at this end of the research continuum. The case started with a single case study, patient 0, you said, case series, RCT, and this is the continuum of research. So we just need to, if you want to be evidence-based practice, you need to understand what the limits of each type of research are. So some really good framing of that from you, Jane. That's good.
And there is some other projects going on around the world. Well, there are coming. So there's a research project, I think, that's going to happen, one in New Zealand, one in the UK, comparing rehab alone to bracing. So, and as you would understand, Luke, it's part of research design is the possibility to get research funded, because the bottom line is you can't conduct these research trials unless somebody pays you some money to do it, because they're very expensive trials to run. So, of course, the first research project that we had to do in Australia was comparing surgery, which is our current gold standard management, to a novel approach, which was the bracing, not comparing bracing to different bracing or bracing to non-operative care, because that's not our standard approach here.
Yeah. So the research funding does dictate some of the study designs that you read. It's something that's worth bearing in mind as you read, as an educated consumer of research, sort of understand how the research was funded, and it's an interesting point as well. So in terms of further learning for people, so you mentioned your course that you're putting together.
So there's just one other thing that I want to add into this as well, is that I think it's really important to understand, for people to understand, that after the 12 weeks MRI, which is, it's still done at 12 weeks, whether you do a 12-week, an 8-week or a 6-week protocol, because we don't see enough definition of healing until that time. And again, it needs to be done with those same sequences. So there are clinics that actually have learnt how to do this, and then they can actually grade the healing from an ACLOS 1, 2, or a non-heal, if that's the case. And then, of course, you need to make sure that you address any impairments from being in the brace, which if you've done a good job through the bracing protocol, there shouldn't be too many impairments. But the typical ones are obviously some people get a bit stiff, some people have some gait alterations, some people have some quads or other muscle weakness or activation problems, and a habitual limp or something like that they've developed. But then you then have to actually undergo standard criteria-based ACL injury management, which is long. Do you know, and we think that it's similar to managing an ACL reconstruction or similar to an ACL non-operative care, where you've got acute, intermediate and late stage management with criteria at all of those stages, and then return to sport, which is really a culmination of their biological readiness, which we think is 12 months at this in the healing group, no different to ACL reconstruction. And non-operative sometimes is a little quicker because they don't have to recover from any surgery, but they still have to achieve these pillars of biological readiness, physical readiness, and mental readiness. So, and so you still need to be able to be knowledgeable enough about ACL rehab, even if you are excited to take up the cross bracing protocol.
Yeah.
So,
and again, back to your shared decision making and education. So it's times have changed where people are really involved, at least in this field under your management and with your team, really involved in the technical details and the overall decision making. Everything from the explaining to them the actual distance in the rupture and the grading of their ACL healing, for example. So they're very involved in their care, which is really important.
Well, and knowledge is just so accessible these days to patients. They can, ask ChatGPT, tell me about ACL healing or the cross bracing protocol. And as I say to some of the younger physios, be careful, because they'll probably turn up to their appointment and they might know more than you, because they've actually looked up all the information that's available online.
We no longer have a problem of information being not accessible. Everything you could possibly want is there. So then it becomes this educated consumer of that information and steering people towards the high quality resources, such as my question from before. ACLinjurytreatment.com, people should look at.
So that's for the shared decision making for non-operative versus operative. It doesn't have a lot about healing yet, because of course it's not high enough quality of evidence to go into that, because it's a Uni Melbourne publication, obviously. So we only had high levels of evidence. And then there's obviously other resources. So the case series publication, where they can have a look at the 12-week protocols. I'm sure that at some stage the RCT protocol probably will be published as well. And then there's the other shared decision-making surveys, one that's already been published and one that's being edited to be published in JSAMS at some stage soon.
In the show notes.
Yeah, in the show notes.
I'll put everything in there.
Yeah, and then of course, I'm just in the process of writing the course for physiotherapists. So we've just finished filming 5 hours of the online course prerequisite materials, which is Dr. Tom Cross talking about the medical considerations, Dr. Stephanie Philbay talking about the research considerations, and myself talking about the physio considerations. And then there's a 12-hour practical workshop, which is everything from brace fitting to rehab through all the different stages, and then criteria-based ACL rehab from acute, intermediate, late stage, and criteria-based testing. So we have all the VOLD equipment that come along. We have brace fitting. So we have with actual braces. So it's a very practical workshop. So that is coming to Australia in July. So it should be available soon. And a couple of courses each year will be taught through the APA and the others through Physio Educators.
The podcast's called Physio Foundations. The big theme has been the foundational, I didn't say basic, but the fundamental underpinning knowledge and skills of the profession. And we've got to make the point here again that this is an extended scope of practice. This is a specialised activity that we're talking about here, but it's really good for listeners if they're at that early stage of their career to get some insight into your clinical reasoning and some of the considerations here for this.
That's right. And I'm always happy for younger physios, if you're interested, to come along with your patient, if your patient gives you consent for that, for me to do one of those shared decision-making sessions with them about what I think their chances of healing with the cross-bracing protocol and what their options are, so that they can learn some of this shared decision-making in clinical practice. So,
that's very generous of you and very generous with your time here today. Have we any final thoughts? Have we missed anything? There's always more, but anything else you want to add?
There's always more, but I think we covered most of it from,
that's fantastic.
The different shared decision making. But I suppose the other pros and cons of the brace, that's the other thing that's probably important to understand, in that, the brace itself, it's obviously time consuming. It can be inconvenient. The best brace is nearly $1,000, so it is not inexpensive, but compared to a gap fee of, even if you have insurance, possibly $5,000, it's still cheaper, but you do need to probably have a few more physio sessions. So there's different financial implications for the brace.
Braces it's a silly question, do they get reused in any way, or they would get thrown out?
They can be, but they're not really designed to be. Some people can, and you can reorder inners and things like that for them. But And look, with the case series, we did use a simple ROM brace, but there is more movement in the ROM brace than the brace that we use now. So which has more, it's more structured and less movement. And
another silly question: can they be taken off at all in the initial phase?
Yes. No, it's not a silly question. They can be taken off for showering, but you need to leave your knee at 90, and they're also taken off for physio. So we normally see them weekly for soft tissue, some patella mobs, some superior tib fib mobs, some all of those things. So that's different to if they're in a plaster.
So that's that's a big part of it, isn't it? It has to stay at 90. So.
Yeah, that's it.
There's a possibility of someone going, I'll give it a bit of a stretch and damage done.
That's right. And then I suppose the advantages, though, is that you really don't have a graft morbidity. So, as you know, when you have an ACL reconstruction, they either take normally your hamstrings or quads or patella tendon. And so then you're also rehabbing the graft site morbidity as well. So, and we've had a number of performers and performing artists who don't want the cosmesis of having an ACL reconstruction with big scars on their legs either. So there's a number of different advantages and disadvantages, which is also part of the informed decision-making, in addition to the tear and the medical and the patient that comes under the patient factors, So,
It's such a good summary. Yeah, complicated, but such a good summary of a complicated topic. Jane, I'm mindful of your time. I know everyone listening to this will be really grateful for that summary. There are you've been on other podcasts. I can put them in the show notes as well. The more information we can get out about this topic, the better. And then you'll link to this episode from your resources, and I'll have it on our platform, and so we'll hopefully contribute to that development of our shared knowledge.
That's right. And I'm in the process of writing a patient website as well. So there will be a number of different resources that people can refer to. So it's just I need to duplicate myself to have the time to do all this in addition to my clinical work.
Yeah. We need 3 or 4 Janes. There's you do the work of 3 or 4 people anyway. So unbelievable.
But thanks, Luke, and thanks for helping disseminate the knowledge that you do, because it's important as a young physio to understand what's out there and what's new and happening, and so you know how to apply it appropriately.
Yeah, and we can all learn a lot from each other. So, especially from a conversation like this, that was really good. Thanks, Jane. I really appreciate it.
No worries. Thanks, Luke, and all the best for all of you listening. It's been a great ride for me, my career, so I'm still loving it. So
And plenty more to come.
Yeah. Yeah.
So here's my cheesy outro. You ready?
Yep.
Until next time, this is Jane Rooney and Luke Perrotin wishing you all the very best with your studying, professional development, and lifelong learning.